Good evening, all. I'm very excited to welcome everyone for the virtual Red Saree seminar series. For those who are new, the mission of Red Saree is to promote healthier lifestyles for South Asians. Please visit the website redsaree.org to know more about our mission. And I urge you everyone to make aware of our friends and family the importance of healthy lifestyle. So some housekeeping rules during the talk are like, please mute your microphones and you can submit questions anytime in the chat window, and they will be asked to the speaker at the end of the session. So today I'm very happy to moderate the seminar in hosting Dr. Khurram Nasir, an eminent cardiologist who is a Jerold B. Katz investigator, also a chief division of cardiovascular preventive and wellness. He's a professor of cardiology and at Houston Methodist, Texas. He's going to talk on the topic cardiovascular prevention in South Asian women. It's a great honor for us to have him today. Really appreciate him for accepting our invitation in spite of his busy schedules, showing his sincere commitment to people health. To know more about Dr. Nasir, he received his MD from Allama Iqbal Medical College, Lahore, Pakistan, followed by his master's in public health from Johns Hopkins University. Later, he completed his internal medicine residency at Boston Medical Center, followed by cardiology fellowship at Yale University. Dr. Nasir also received his postdoctoral research training at the Division of Cardiology, Johns Hopkins Hospital. He also recently earned a master's degree in health economics and policy management from the London School of Economics and Political Science. Dr. Nasir is also a fellow of American College of Cardiology, fellow of American Heart Association, and fellow of American Society for Preventive Cardiology. He also serves on the board of directors for the American Society of Preventive Cardiology. He was honored with the Johns Hopkins Distinguished Alumnus Award in 2013 for his personal accomplishments, professional achievements, and humanitarian service. To his credit, he's also an accomplished researcher, as Dr. Nasir has over 500 peer-reviewed articles that are published in topmost journals like Lancet, New England Journal of Medicine, JAMA, etc. Thank you, Dr. Nasir, on behalf of Red Saree. Now the time is yours.
Perfect. Venkat, can you hear me?
Yes, go ahead.
Well, first of all, the honor is tremendously mine to be invited to this society, which is taking the lead in helping our community understand the risk and trying to prevent one of the most important aspects from a healthcare standpoint, heart disease, and especially in the vulnerable group in women. So I am honored, humbled to be invited, and hopefully I'll try to keep it brief so I can learn from everyone's experience out here. So as a preventive cardiologist, I think so over the last 20 years, it's very satisfying to see that we are seeing a significant decline in heart disease, more so that I'm hoping that we can lose our status as the #1 cause of death in the country. However, at the same time, although I want to take credit to a lot of the things, the good things that have happened, but in truth, the death from heart disease has mainly improved because we have significantly enhanced our capacity and our ability to once patient have a heart attack, we have ability to take them quickly to the emergency room. We have made significant advancement in quick procedures such as interventions, placing a stent, and other technologies, bypass surgeries, how we maintain the ICU and CCU. So we have done fantastic, but thanks to most of the efforts that gets started once you have an established heart disease or a heart attack. Now, at the same time, over the last 10 years, and especially in our communities, we have seen a significant shift in the industry, leading to more sedentary work life style. Of course, westernization has also occurred in various parts of our original countries, but more so in US. As a result, we are seeing significant increase in obesity, high blood pressure, diabetes, and more so a silent risk factors, especially in South Asians, is the pre-diabetes, where we tend to have much higher, about 3 to 5 times fold higher increased risk of that. Now, as a result, although what we have made significant gains, eventually what we're seeing is that in the last 5 years, the gains that we are have appreciated because of better procedures, better access to the care, and better medicines, actually we're starting to lose the battle again, and especially among Americans under the age of 40 years of those having heart attack. And of course, if you would recognize that Luke Perry, at a very young age, 52, died from a stroke. This is not a single story. This is a grim reminder that many in the young are dying much earlier. Now, it's a startling fact that we see in our communities, especially among men, and now I can tell you women are not immune. That if you look at a community, for example, California, Asian Indians rate for hospitalizations are about 4 times higher than any of their other Asian counterparts. Now, I can tell you a personal story. My dad had his first heart attack when he was 41. Many of my uncles and friends of my dad, almost all of them have their first heart attack at late 40s, early 50s. And I can tell you that back home, and I'm originally from Pakistan, from Lahore, and my wife's who's from Delhi, we talk about it that having an early heart attack is considered normal. It's a fact of matter that, yeah, I had the disease, I had a stent placed, or I had a small heart attack, and everything's fine. Now, that the question is why, and where are the challenges? The problem in the US is where we have 4 million South Asians. We haven't really figured it out yet because we lack the data. And even in our own countries, we haven't really figured it out how to understand why South Asians, men especially, and not that women are immune, are having much early heart disease. So some of the efforts have started, and I'm sure from the Masala study, we have started to at least learn that, number one, it's very clear that South Asians develop heart disease approximately a decade earlier than people of other ethnicities. So when I start seeing other ethnicities, I'm seeing heart attacks in their 60s, whereas in 50s in the South Asian is pretty common. Yes, overall obesity by the conventional matrices is not that common. However, if you take even in non-obese, of course, we have a more bigger abdominal obesity. Almost half of those have more risk factors for heart disease compared with only about 21% of normal weight whites. And we develop type 2 diabetes, and I mentioned insulin resistance, blood pressure, triglycerides, and high cholesterol, even at lower body weights than the general population. Now that it is becoming clear that the South Asians are almost 4 times higher risk of heart disease, and unfortunately there have been this population has not majorly been studied, and in the past we were put all together in this whole group of Asians, and we know we're not a monolith, and there are huge risk factors, cultural as well as actual biological differences. Thankfully to our Congress, and especially Representative Jayapal, who has been a fantastic champion of South Asians' cardiovascular disease, we got a bill passed a couple of months back, almost a month and a half back, that eventually there is going to be much more support with respect to the NIH and the federal funding to understand why young individuals and South Asians develop heart disease. And we are leading some of the efforts. One of our star fellow, Priyanka Satish, who just moved to Houston for her cardiology fellowship from Cleveland, is showing that nationally suboptimal heart overall health, which is at least 3 risk factors, although we tend to believe that Asian Indians are going to have much more higher burden of risk factors. Actually, it's not that true as compared to whites, and especially Filipinos tend to have much higher. But despite we don't have such clear-cut risk factors which are glaring, we tend to suffer a lot of heart disease. The question is why? And as a result, one of my star cardiology faculty, Dr. Miguel Canzos, who came from Spain and actually did a lot of work in the South Asians community out there, is now just submitted an NIH art study that we will be recruiting almost about 200 individual South Asian in Houston, which is, of course, a big hub for the South Asian community, and do some more deep phenotyping. We want to look at very extensively in multiple beds, whether they have any plaque, look at their blood, inflammation, social determinants of health, and then collect that data eventually to create a much larger study. And hopefully these studies should come to your major hubs in New York, DC, Chicago, Dallas, San Francisco, and LA. But we are not only content on that, we are pushing the envelope and actually taking some of what we are trying to learn here back home in our countries. And I'm hoping to find some more hubs. Right now, with our partners in Pakistan, in Karachi, we are recruiting 200 individuals to do a very advanced CT that not only looks at if you have calcifications, plaque buildup in your arteries, but also what type of plaque. And rather than looking at elderly, where most of the data is, we're really going much earlier, in less than 45 years, and we'll be adopting a similar protocol for a study that I did in Miami called the My Heart Study. Thankfully, we have been able to raise almost $500,000. And I think $500,000 goes a long way in our countries. And I hope Red Saree and other communities, advocacy community, can work with us and also like-minded partners to find similar projects in other parts of the South Asia, in Sri Lanka, in Nepal, and in India, of course. So, but all I wanted to tell you, there are very big knowledge gaps. I wish I could be here today talking to you about what we have already know. But unfortunately, we don't know much. And I'm hoping in next 5 years, I'll come and tell you why young individuals, we develop so early atherosclerosis and clinical, and why there are sex and gender differences that we see in other groups are not as tremendously different. Women are also at a higher risk. And what are the social determinants? For example, of course, biological, we understand, but what about our diet cultures? But what about our stress levels and our acculturation and the duration that we stay in the US, and the environmental factors? What would it? But till then, at least we have best practices. And I think so this is a community that we need to emphasize again. And there are some excellent messages that I want to pass on. The first thing is, I grew up seeing these pictures, or even remembering that, okay, this is really heart attack. Somebody has a heart attack, they're going to have crushing chest pain, and they will be grimacing in pain. And usually it's happened when I'm trying to walk uphill and I can't walk up the stairs, and it's very gradual. And this is true. But actually, in real life, this is a heart attack survivor. And similar, I have seen 3 women this week with similar stories who didn't have any of these symptoms. All they had was indigestion. And their symptoms were attributed to anxiety, and was saying, well, maybe it's acid reflux. And in the end, they tend to have a heart attack. So while these are the classic chest pain symptoms. For example, if you're going to get a chest pain and suddenly you're getting more short of breath, and this pain is going to your arm, your back, and jaw, shoulder, those are absolutely important. But in women, and most of the women who are watching in your middle age, if you start getting these symptoms, please do not ignore them. For example, Hardman-like symptoms. One of the symptoms that's not out here is getting anxious. That can be an early indicator of reduced blood flow to the heart, and sudden dizziness or getting nausea and vomiting, and you're getting unusual tired. That could be an indicator of a significant blockage. So it's very important for the women in our community to not to ignore these symptoms, because what happens is um, the maternal instincts always is out there, and the women tend to underestimate what they have. And I'm telling them, don't miss a beat, make a call. Only about half of the women say that they will call 911 if they're experiencing even the classical symptoms of heart attack. But almost more than 2/3 will say they'll call some if the 911 if someone else is having heart attack. And because also the lack of expected symptoms or lack of knowledge leads to delay in the care. And in heart disease, uh, time is muscle. For example, not only for South Asians, but all across the US, women are ignored. For example, if you're coming with ST elevation MI, this is the classical heart attack that is caused by likely a clot in the artery that causes the damage of the heart muscle all through the wall. And even in large metropolitan regions, for example, in Houston, New York, and Chicago, San Francisco, we are seeing that almost there is a half an hour increase in the time from when women or men have symptoms to the first medical contact. So a 60-year-old female having heart attack symptoms versus a 60-year-old male will have their first contact half an hour late. And that is a difference between, could be from having a fatal heart attack, a major heart attack that can cause debilitating symptoms all through. And not only, even if you have the contact to a point where they will take you, and this is the standard of care, where patients presenting with these type of heart attacks, the best treatment is taking them to the cath lab, taking a wire all the way into their heart arteries and opening up the clot and putting up a stent. That's called reperfusion. Only about 15 minutes increase in time. Clearly we have a lot of work to be done. But not only women are, unfortunately, they don't recognize their symptoms, and I hope after this lecture they will be recognized, but women are also less likely to be initiated or preventive therapies. Even among those who had heart attacks and who should get the cholesterol lowering pills and the aspirins and their blood pressure medicines and medications that can slow the heart rate. And they're also less likely to continue those medical treatment, and they're less likely to be a treatment on after 1 year. And the greatest disparity and the challenge is especially when we're seeing women in the younger age group. So there are many quality issues. There are gaps in cares that include recognition, treating, and if you treat, once you have the disease, not optimally treated. However, as a preventive cardiologist, I hope that we can solve the problems by, first of all, never have a heart attack. And I can tell you that it is preventable. And of course, we have a higher genetic, we have some environmental, some social risk, but there are ways. But the problem is, like many of you in this room today, and we're in the rest of the country, how do we even recognize that one person who's at risk? That's really the key. That's the $1 million question. Now, there are some best practices. And of course, the first thing is accurate risk assessment. It's always a doorway to prevention. It helps with questions such as, And you should be asking those questions, especially if you have a strong family history in the heart disease in your family, or you have some risk factors, or after a certain age. I think everybody South Asian after age 40 should be asking this question and then saying, am I at risk for heart disease? And I just received a call from a friend of mine in Cupertino, whose young cousin at age 50 had a heart attack. Now every member in the family, yeah, and no risk factors, and they're panicking and say, what is my risk? And if I am risk, how intensive should my preventive strategy be? The general gateway is using an equation called the pooled cohort equation, where you go to a primary care, and that's kind of what methods are done. Really, they take into account your age. For example, a 52-year female, of course, white. If not, you're going to have other. Unfortunately, we just don't have South Asian specific risks. And the blood pressure is almost mildly elevated, and the cholesterols are kind of general, what we see in our community, no history of diabetes, or maybe a former smoker, in the sense that socially smoke and quit 5 years ago, the blood pressure on a high blood pressure therapy, no statin therapy. So if you look at the risk, it says you are at a low risk. But again, you can see there is a lifetime risk of almost 40%, even with a much lower risk score of 2.5% in the next 10 years. But again, one of the key things is, and you, based on this risk group, you would ask, okay, should I get statin, the cholesterol pill, or the heart attack reducing pill, or aspirin? And usually, unless your risk is not more than 7.5%, you are not recommended to get that. Now, I feel that these risk scores, they have an age and a gender bias. And let me tell you why I think so. So if you look at the national data all across the age groups, so here are men, and red is where individuals are considered pretty high risk, and individuals, yellow is intermediate risk. That means you should do some testing or some figure it out. So almost more than half of the males above 50 get into a point where they're pointing to us that we should do something about that, and almost everyone above 60. But here in women, almost 1% and less than 5% out here. Now, this is where I see that women, if you're a woman age 50, there is only 1% chance that your physician would even think about you at a risk where they may want to do something else or do some more further testing. And only about 10% of women age 60. And this is true even for the South Asian communities. If you take the same risk factors, actually, it may underestimate the risk more. Whereas if you're a male, at least when you see your cardiologist or your primary care doctor, there are some flags saying, hey, do something about them or look for risk. But in women, we are not even being pointed to that. Now, how good are strategies in preventing heart disease? So let me show you another example. About 200 individuals. This was a study that really changed the way I looked at risk factors, and I wanted to do more. About 200 individuals who presented with their first heart attack and have women who were less than 65 and had no diabetes. And what if these patients came to my clinic a week before? And I do the risk factors and say, how many of them would actually, I'll say there are high risk? Not many, only about 10%. Actually, 3/4 of them, I will look into their risk factors and look into their eyes and say, hey, you're all fine. We don't need to do even testing for the next 5 years. And next week, they'll have a heart disease. By the way, these numbers go up to almost 85% if you're a woman. Then there is also a myth that it's all about high cholesterol. And yes, of course, the higher the cholesterol, it's very important. But if you look at our national data set of how many patients who present with heart attack, almost about 75% have their LDLs, which is considered within normal range. And if you look, more than 50% of them have less than 100. And this is the numbers that we want to target, less than 70 even in heart attacks. So almost about 20% have even less than 70. So it's And the rationale why I keep on telling you that just because you're age 45 and you're not worried, or you're at least not thinking about the risk of heart attack because your cholesterol is normal, just remember almost majority of individuals who present with heart attack have normal cholesterols. So now the question is, okay, you're saying, well, can I trust the risk factors, or what do I need to do more? And uh, also, as a patient now, I can give you a pill and say, well, why don't you take this magic pill, which is called statin, that not only lowers the cholesterol, but reduces the risk of having a heart attack and stroke. And now you need to take it one pill a day for the rest of your life. Most of my patients, and including myself, and I say, why are you telling me that? Am I actually at a higher risk or not? And because this day and age, I'm seeing most of my patients are reluctant to even take these medications, and they read online about statins, and especially in South Asia. When I go back home, none of my relatives who had heart attack are even taking those pills. They are very reluctant to take those medications. So my whole theory is that in the younger age, if you didn't have a heart disease, rather than trying to focus more on your risk factors, which are, by the way, important, but your main emphasis should be on atherosclerosis. Atherosclerosis means the plaque that develops in your arteries, and it could be your heart arteries and your neck arteries or your brain arteries, where it starts from a small process of after inflammation and accumulation of the fat, and it get unstable, that could rupture, and then clots happen, and it can cause a heart attack. So what if we are able to identify individuals who are at risk before they get here? Is there a mechanism that we can look into the heart arteries? Now, that is where these type of things will happen, especially if your risk is still uncertain. So what I'm trying to show you right now is a very simple modality called the CT scan that looks at early plaque buildup in your arteries in form of calcifications. And this test was first introduced in the 1990s by a dear friend of mine, a colleague, Dr. Arthur Eggerson, and also famous for the South Beach diet, that showed for the first time that you can pick up these plaques, earlier signs of plaque, like a mammogram, without even giving a contrast. And this test is widely available, and although it's not yet covered by insurance, which should happen, but the out-of-pocket cost in many places, almost all across the US, is somewhere between a $55 to $100, and the radiation is equivalent to a mammogram. And what it tells is truly, for the first time, a test that has the same power in predicting how many men and women will have heart attacks. So here's the axis that showed over the next 10 years how many individuals would have heart attack, and these are the years. So you can see this is calcium greater than 300. That means you have a lot of plaque. You have moderate, mild, and none. So if among women or men, if you have no plaque, in your next 10 years, less than 5% individuals will even have a heart attack, as compared to 20% women, 1 in 5 who would have heart attack or stroke, and same thing in men. Now, the beauty of atherosclerosis, I tell my patients that although there are many disparities and inequalities, the good and the bad part is atherosclerosis does not discriminate. If you have atherosclerosis or plaque buildup in your arteries, you're at the same risk if you're a male, female, African American, Hispanic, Caucasian, and even South Asians. So this is the main arbitrator. So if you have higher risk, you need more aggressive treatment. Now, I want to tell people is that there are many of individuals who not only it identifies who needs treatment, but this test can also tell you people who may not need to be treated. For example, we showed that individuals who have multiple risk factors, almost 1/3 of them have no disease. On the other hand, if you have no risk factors, that includes diabetes, hypertension, smoking, high cholesterol, family history, or obesity, about 22% individuals have some early plaque. and about 12% will have significant amount of disease. Now, in real life, I would reassure these individuals and aggressively treat, whereas I'll then miss all of these and then unnecessarily treat these 35 individuals. Now, the same thing with the cholesterol. For example, you may have the worst bad cholesterol, which is your LDL, or the good cholesterol, and the fat cholesterol, triglycerides, but still half of those individuals will have no plaque. On the other hand, you can be very happy about having all normals, but about 42% and 20% will have very high level of atherosclerosis that we may miss. And when you follow these individuals for the next 10 years, as you can see, that even among those who had the worst risk factors, if you have no atherosclerosis, which we call the power of zero, your risk is much lower, only about 2.5% in the next 10 years, as compared to even the minimal risk of plaque in absence of risk factors. And same will, you can see with the number of lipid abnormalities. That's LA means lipid abnormality. So you can have all the lipids abnormal and have no plaque. Your risk is much lower than somebody who has minimal plaque but no lipid abnormality. And once you go into this red zone, that's the danger zone. That means if you have moderate amount of atherosclerosis, if you don't do anything, almost about 1 in 5 to almost more than 1 in 4 will have a heart attack in the next 10 years. And you say, well, why is this such a good risk factors? And my answer, it's not a risk factors. The risk factors are, for example, your genetics. If you have genetically, you are predisposed to developing atherosclerosis, or traditional risk factors like obesity or bad diet or diabetes, or some novel risk factors that we are still merging, because just because you have risk factor doesn't mean it's an insult that you will develop the damage, and just because you don't have the insult doesn't mean you don't have the damage. So calcium integrates all of this. It is the disease. So it's very simple. If you have CAC testing and your calcium score of 0, you downregulate the risk and reassure the patients, like I do most of my days, where a lot of patients who have multiple risk factors and are worried, and I reassure them that it's not too bad. It's a wake-up call. Let's work on your risk factors and make sure that you never develop atherosclerosis. And people who have calcium greater than 0, even if they don't have risk factors, I tell them for reasons unknown, they have developed plaque and we need to work with them. So it's come to a point where, based on a lot of our work, before even considering statins, everybody is saying, talk to your doctor. This is Dr. Scott Grundy, one of the leading investigator, and also the lead of the guidelines, one of the major leads. It says, if you have no chronic calcium, your chances of having a heart attack is very low. So the message what I'm trying to say is, for all the people who are listening, if you're age above 40, irrespective of your risk factors, but especially if you have some risk factors, try to get a heart scan. It's not covered by insurance. It's a 55 to 100 out of pocket, but it will provide you significant information that can guide your physician and cardiologist to optimize and create a more personalized, tailored therapy and a preventive program for you. But again, of course, we want to assess the risk. We want to find if you have plaque and then treat you. But again, irrespective for that, and especially if you have it, we need to focus on lifestyle approaches and other risk factors. It's not all about the cholesterol. I know that most of us are well attuned and know, well, you have high blood pressure if your upper number systolic is more than 140. But actually, nowadays, normal is less than 120, not less than 140. And actually, your blood pressure is high and you have hypertension if your blood pressure is more than 130. So remember that your optimal blood pressure number needs to be the top number less to be 120. You have elevated blood pressure if it's more than 120, and you have hypertension, it's greater than 130. And yes, of course, at some point, these individuals may need medications, but truly it's about lifestyle. And I tell patients 4 major things among the recommendation. Reducing salt. I know South Asian food myself, I have to remind myself on cutting back on adding extra salt. limiting alcohol, especially hard liquor, beers, of course, occasionally red wines are fine. And also going into a structured physical activity program. And I'll talk a little bit more about that. And weight loss. And although for us, weight is not a major issue, it's really the obesity around the abdomen. And of course, lifestyle issues are the ones which dictate that the most importantly. So remember this. Of course, these are the lifestyle interventions that you need to do. But if you have diabetes, kidney disease, or your 10-year risk is more than 10%, that means you may have some plaque in your neck arteries, the heart arteries, or you have some risk factors. You need to start treatment, blood pressure medications, and try to get your numbers below 130. If you have none of these risk factors and you're leading a healthy lifestyle, it's okay not to start treatment, blood pressure medications, if your blood pressure is less than 140. So very important, know your numbers. It's very important for you to understand that high blood pressure is greater than 120. You are hypertensive, it's greater than 130, and you should definitely get blood pressure medications if the upper number is more than 140. Now, as I was talking about the lifestyle factors, nutrition and diet is very important. I see a lot of patients, everybody is talking about, there are many healthy diets. And now these days, of course, keto has become an interesting dichotomy where people are going towards a very high fat diet. But actually, if you use the more healthier fats, as shown in these pictures, nuts, salmon, avocado, olive oil, legumes, and then you have paleo diet, which is more again looking at the nuts, vegetables, fish, and a whole plant-based diet, and then the South Beach diet. Those are the key features of all of these diets are almost no sugar, cutting back on refined carbohydrates such as wheat, white bread, rice, pasta, smaller plates, more balanced diet. But unfortunately, if we look around, and again, every day I resist the temptation of the delicious food that we have to offer, which doesn't really seem to fit any of those. And considering that a majority of our population is vegetarian and we think that's plant-based diet, but we do supplement that with a lot of, I would say, not so healthy fat, a lot of a very high carb diet, which is more high in flour, rice, not more pasta, but a lot of things like, as we're seeing, which are high in fat as well as carbohydrates. And yeah, I tell people we can have a healthier diet, which is not optimal because we end up tend to cooking all of our vegetables, and even rather than grilling, we tend to have more curries requiring a lot of oil, and of course we tend to have too much of the bread. So I tell people to cut a little bit back on that, grill this one, and of course trying to stir fry some of the vegetables or use them more raw than trying to have them mixed with most of our curries and dals and things like that. So that's one. Then it's physical activity. Now, there are two things that you need to understand. There is one thing being physical active, and then there is one thing as exercise. I speak with a lot of my patients and I ask them, are you exercising? And then say, yes, I walk all the day in the house doing my housework, and at work, I'm walking about 5,000 to 6,000 steps. And I tell them, yes, you are physically active and you have reduced your sitting time. Of course, that's kind of a conscious effort that we need to make in our offices, in our homes, in our travel, and even at work, if we can stand more and walk around more. So if you are walking more than 10,000 steps, you are physically active, but that's different than exercise. Exercise means is pushing beyond your limits for a certain amount of time, increasing your heart rate above and beyond the normal times. For example, brisk walking or walking a dog. So 30 minutes of exercise. Moderate is like walking a dog And vigorous aerobic exercise is jogging, running at least 4 to 4.5 to 5 miles an hour. So those are two different things. Now, if you look at the spectrum of the benefit that you're going to get from physical activity, it's kind of the highest benefit starts, especially if you're not physically active, to a point if you can push yourself to 150 minutes of moderate intensity per week. That's like walking a couple of miles, a mile and a half a day for 5 days at a moderate speed, or running or activate participating in a game of tennis or rowing or swimming for 75 minutes for vigorous health. That is your optimal level. And this is really getting beyond that. You're becoming much more physically active, but higher is always better. But at certain point, you're going to plateau the effect that after that, if you're running marathons or anything else, it's not going to have more benefit. And we don't really know, after a certain point it may actually cause some reduced benefit. There are some studies that are looking into that. But truly, moving from a couch potato to, even if you're doing 5 minutes, 10 minutes, 15 minutes, 20 minutes, 25, you are going to have a benefit. So I tell everyone and my patients in our community, especially in the South Asian women, any exercise is better than none. There is no lower limit. The higher, the better. The other thing is, of course, the obesity, age adjusted obesity is growing in the US adults. In the South Asian community, although we do not have the traditional BMI based obesity, but the abdominal waist obesity is also than most of the other populations, at least the other Asian groups that we have. Now, if you have an abdominal waist, especially more than 40 centimeters in men and 36 in women, and you know your weight, there are ways of achieving healthy weight. One is, truly, I tell people that if your BMI is more than 30 or you're definitely much overweight, to get involved in a comprehensive lifestyle program. Having that face to face, or now these days telephone delivery weight loss program, will they'll truly guide you what are the best ways to exercise and how to create a more balanced diet. And really, in the end, you will have to reduce your calorie intake by 800 to keeping it to around 1500 calories a day. So you start by reducing your calories by 500 kilocalories per day. You know what's 500 kilocalories? That's almost two pieces of naan. So if you can reduce something like that, that's a great start. You need to supplement with physical activity to increase your basal metabolic rate, almost trying to push yourself getting to greater than 150, because achieving healthy weight is the key to success in the South Asian community and in our women community, because this is the basic foundation that leads to diabetes, hypertension, inflammation, and then eventually plaque. And then make sure that as you start, you are monitoring. You are getting up on your machine every day. They're recommending weekly, and I'm saying measure it every day and aim for at least a 5% of your body weight that's reduced in about 2 to 3 months. That is going to be very important. So achieving, making a note of what your BMI and what your abdomen obesity is and what should be the right way. Take action right now. If you need help, seek help. Cut back on the calories. Be mindful. There are now many programs on the internet. I've used myself and my patients a program called Lose It, where you put in all the calories that you had and it tells you how much you had. Try to keep it between 1500. Reduce to naans at least, or a big serving of rice. Exercise every day and measure. That's the critical things. Of course, if you're type 2 diabetes, you need the medications. But again, uh, the South Asian diet may not, which is heavy in carbs, may not be the best. I strongly suggest moving into something like Mediterranean. Even if you're using a vegetarian diet, less oil, less carbohydrates, you should talk to a registered dietitian, nutritionist, and a diabetes education program enroll if needed. It's not all about medication. Losing weight is going to be improved. And again, none of these is going to happen without exercise. So a combination of aerobic as well as resistant training, weight training also helps. The goal is really to improve weight, and it will improve the glycemic control. And not only in our community, we have a higher risk of diabetes, but we see a lot of insulin resistance, the pre-diabetes. I think so that's a bigger menace. So don't wait to get to diabetes. Start these interventions even when you are pre-diabetic. Of course, now I know that in our community, I see a lot of patients who are taking aspirin, but not statin. So aspirin is great if you already have an established heart disease or stroke, but we need to balance the benefit that it will have in reducing the heart disease and also the bleeding risk. So before starting aspirin, you need to make sure that your CVD risk is higher. So either you have an established CVD or you have a very high level of calcium, as I showed you on the CT scan. And make sure that you balance it if you have any prior bleeding from the GI or any other side. If you're more than 70 years of age, if you have kidney disease, and if you're using any other non-steroidals like ibuprofen, etc., steroids or other blood thinners. So make sure you speak with your family doctor about that. And it's all about your preferences. The patient and clinician needs to discuss. Nobody should be prescribing you medications without your involvement, where you understand what's your risk, what's the level of benefit. I tell my patients the role of a physician is not to enforce, is to inform. It's not to dictate, but to guide. And that's what we are here for. So ask your physicians, why are anyone, if they prescribe you a medication, why, and what are the alternates, and what are, I would say, the side effects, and the what are the other options. So please take charge of your own health. So in summary, I'm just going to give you some hashtags. Is assess your risk. Make sure after age 40 everyone gets at least a comprehensive assessment. You should use the pool cohort equation, which is promoted by the ACC, that takes into account your age, your sex, your blood pressure, your glucose level, your cholesterol, whether you smoke or not, and gives you a summary. And if you are in that mid range where you're not sure if you're low risk or high risk, define it by a CT scan, 75 to $150. It looks and find plaque. If you don't have plaque, that's good news. That means focus on your lifestyle. If you have a lot of plaque, that means it's good news again, because you have found the disease much early, and then you would need much more aggressive interventions. So number one, assess your risk. Number two, antiplatelet therapy. That's rethink about aspirin. Just don't take aspirin for primary prevention if you do not have a lot of atherosclerosis, because there is a risk of bleeding. And if you had established heart disease, then aspirin will be helpful. But before you take it, make sure that you balance it by other risk factors. For blood pressure, please remember 120 is the new 140. For blood pressure, lifestyle modification is the first thing. Exercise more, lose weight, cut back on alcohol and salt. If you are high risk, for example, heart disease, kidney disease, diabetes, or stroke, then you should take a blood pressure if it's greater than 130. And if you don't have them, then only if it's more than 140. For cholesterol, it's an important risk factor. Just because you have mildly elevated cholesterol doesn't mean you need a cholesterol pill, and just because your cholesterol numbers are normal doesn't mean that you don't have the plaque buildup. So rather than focusing too much on just the cholesterol numbers, do a calcium score. If you have zero, which is called the power of zero, you can be flexible and avoid. If you have early plaque, at least you have found the substrate to treat more aggressively with the cholesterol lowering pills. Tobacco, I tell everyone, it's never too late to quit. I know it's hard. use lozenges, use gums. If you are smoking much earlier, you use it more often. You can even think about e-cigarettes, although I'm not a big fan, but at least it helps you move away from cigarette smoking. The one number thing that you can reduce the risk is by quitting smoking. Although we in the past we haven't seen that much more smoking in our women's community, but it's on the rise. I tell everyone, irrespective, ask about cigarette and tobacco. This is the number one thing that we can help reduce the risk of a heart attack and a stroke. Diabetes. Screen high risk adults even much earlier. For example, if you're overweight, if you have a family history, if your diet is more carbohydrate rich, if you live a sedentary lifestyle, assess, make sure that you ask yourself, what's my glucose number? Make sure you're not pre-diabetic, because it's much easier to stop the progression there than it becomes diabetes. And of course, again, like blood pressure, lifestyle modification is first. It's all about weight loss, carbs control, carb control, and exercise. I cannot emphasize more. And in the diet, it's very simple. Eat more vegetables, more less extensively cooked vegetables, fruits, nuts, legumes, whole grains, and fish. Portion control. Less refined carbs, less naan, less rice, less pasta. Exercise. This is, if this was a pill, this would have been $1 trillion pill. This is the holy grail of longevity. If you can get into your schedule 150 minutes of moderate exercise or 75 minutes of vigorous exercise a week, it triumphs almost all the other risk factors. So, in the end, it's as simple as A, B, C, D, E. A, assess your risk. As I told about calcium, think about calcium score, age 40. Don't take aspirin discriminately unless and until you have high risk. As I told you about blood pressure, make sure your blood pressure is less than 130. Cholesterol is an important factor, but not the only one. So when somebody says your cholesterol is normal, don't completely buy into that your cholesterol is normal. You can still have atherosclerosis and vice versa. Cigarette. Stop the cigarettes. If you need pharmacotherapy, go through that. Diet and weight, we spoke about diabetes and exercise. So in the end, if you can take this picture and put it on your fridge and look at it every day and try to achieve those goals, not only yourself, but as a family, I think so is good. So this is kind of the big message. And of course, we're heading into Thanksgiving and Christmas, and I'm sure I'm missing the snow. I just moved a year and a half from New York, but for all my friends in the Northeast, Northwest, where you may have a boom of snow, I wish I could go back to the snowman, and again, which I used to tell every year, lose some weight, quit smoking, move around, and eat the carrot. But again, thank you so much for your time, and really appreciate the honor of presenting to this group. And I would love to hear your thoughts and any questions.
Thank you. It's really, really wonderful overview of cardiovascular risk prevention. This is it's really much needed information, and specifically for our community who are like more prone to. Everyone knows that we are more prone to cardiovascular risk. So let's go to the. There are some questions in the chat room. Let me ask my question first. Like, so what are the places these calcium scans are available? How do we insist our primary care physician, to, as you know, like everyone relies on like this cholesterol panels, like blood. How do you
The
look at this
heart
one?
scans, the CT scan of the heart, or called the calcium scores, are available in every institution. So every place that has a CT scan is able to do that. So all you need to do is speak with your primary care or your cardiologist that I've heard about this calcium score. You can look it online and just let them know, and they need to just prescribe it. The only challenge right now that it is not covered by insurance, so you'll have to pay out of pocket $150. Right now, our petition is with CMS and with very other insurance companies after a lot of the data that has come out, which I've shown you, that we are hoping that it will be able to cover. But it's available almost in any institution, and all of your primary care physicians, but definitely cardiologists would know about it, and you should definitely insist on it.
Great. So a question from Dr. Sakti: what is the upper normal limit of LDL and HDL levels in South Asians? Are these levels different from other ethnicities?
You know, the definition of normal has shifted. And I get a lot of patients who say, but my LDL is normal or my LDL is high, because in our community, we think LDL greater than 130 is high and less than that is normal. And HDL, we think for women, greater than 50 is normal and less than 50 is abnormal. And I tell everyone, I don't know what's a norm. Of course, if you go more towards high side, like that's abnormal. But even among that, it matters why are we concerned about cholesterol? We're concerned about cholesterol because it's the fuel that can potentially accumulate and cause plaque buildup in your arteries, your heart arteries, your neck arteries. That's the substrate that, if it progress, can cause blocked arteries, or it can cause reduced blood flow. And if it ruptures, increases your risk of a heart attack. Now, just today in my clinic, I saw two women, almost similar age, mid-50s, similar risk factors. And she was from Philippines, and the other was, so one woman had bad cholesterol, LDL of 150, which was on the higher side. And the other woman had no other risk factors, minimally elevated blood pressure, and LDL of 102. So the one woman was concerned, she was happy, we did the heart scan. The woman with normal LDL had plaque. The woman with higher LDL didn't have plaque. Based on our decision, we focused on lifestyle more on the women who had a high LDL and say, look, you're lucky, let's focus on the lifestyle. You have flexible choice. If needed, we may not even need to start you on a statin therapy or the cholesterol, or if needed, a low dose. But for the women who had a normalish cholesterol, we are now pushing her LDL below 50 or 55 and giving her the highest dose of statin. So over the last 10 years, our thinking has evolved. So we don't think there is any such thing as a normal range. Of course, if you are at the extreme of high LDL, that needs to be treated very aggressively. But in the range that where most of us live, I would say do not be reassured too much with a normal LDL. Yes, in our community, our HDLs are a little lower than the rest. But again, it's meaningless if you don't look at intent. What matters most? Do you have plaque or not?
Right. Okay, that's a great answer. So, what is the major reason do you think for the belly fat?
You've asked $1 trillion question. If we knew, then that would be magic. There are some diseases which have a very strong genetic predisposition. So, for example, cystic fibrosis, or many other like ALS. And heart disease is very heterogeneous. Heterogeneous means that there are many inputs. Where you're born, where you grow, your childhood experiences, your environment. So now we're learning exposure to pollution increases the risk of plaque development. Increase stress, mental stress. Now, food insecurity, not having the right type of the food all through their lives, exposure to smoking, your own smoking, and cholesterol and hypertension. So each risk factor adds on. So it's kind of like a risk prediction model. So the more information you have, I can predict more importantly. However, what we found that yes, truly, if you have put in a lot of input, it predicts the risk better. For example, the more risk you have, the more likely you will have the disease, and less risk is less likely. But then, if you do the heart scan, there are many people, although it's predicting about 30% people who you would say no risk factors, they'll have the plaque, and then about 35 to 40% who you would treat aggressively and pat yourself on the back have no plaque. So what we are asking is that, rather than trying to predict, why don't we just do a simple test and look? Rather than making a guess, let's see and make a decision that will help everything. Because if you have plaque, your risk is much higher than somebody who doesn't have plaque but a lot of risk factors.
Yes.
So that's kind of where we are going. I know there is a question, is there a blood test which can detect risk for CVD?
Yeah, that's the next question that I
we have been spending the last 20 plus 30 years. That's the holy grail. So right now, the blood tests that we have, it are the risk factors. So for example, we have the test that tells about if you have inflammation, and we know inflammation can cause atherosclerosis. And the blood test tell if your cholesterol is high, low, it's dysfunctional, or if your glucose is high, low, or your kidney function is not bad. So those are blood tests. Those are all risk factors that go into the funnel, and then eventually it comes to the risk. Unfortunately, there is no blood test yet that tells about your plaque buildup. And the rationale, and we haven't been able to, why haven't we able to discover that? We haven't discovered that because we never had our ability to look in your heart arteries of the plaque buildup accurately in the past. And of course, the discoveries usually happen when you take these few hundred individuals, thousands of individuals who have plaque, don't plaque, get their blood and run genetic testing and see what genes are predicting or proteins are signaling that you have plaque. So we don't have that yet. Our groups and a lot of other groups are working in that direction that will actually trying to figure it out, the risk, whether you have plaque or not. Like take a blood drop that can say you have plaque or not yet. And that's why, rather than relying, of course, those risk factors are important. I tell everyone, of course, we have to control them, but what we need more is make sure that you develop your test for the atherosclerosis, because if you have atherosclerosis, then we can work on those risk factors. But do not rely on blood markers yet on predicting risk for heart disease.
Okay, thank you. So another from Dr. Annie Thomas. She's asking, I believe the social determinants that might cause cardiovascular issues among South Asians, life imbalance and lack of facilities to engage in outdoor exercise are two major issues on this.
I couldn't agree with you, Dr. Thomas, that unfortunately, and this is a problem that's not only for South Asians, but I can tell you even within US and other populations, we have never had the ability to capture and study social determinants. So for example, if you look at the social determinants, there are 6 major domains. One is economic instability. And there are many things that it's not only about your income, it's about the type of the job, your financial distress. So now we're looking at that people who are distressed about inability to pay rent or college, or putting food on the table, or the next month's rent. Those are all factors which are related to heart disease. And then there are factors such as around education. It's not about the degree, it's about your health literacy, about your digital information, where we're seeing a huge digital divide about all of those informations. And then your neighborhood, where do you live, the places you have, pollution, and do you trust your neighbors, or do you work out with them, and your social connectivity, do you have a huge network of social network. And that's, of course, it seems to have, at least for the South Asian community, we have seen in not only in US and other companies. And the food, it's not only about the type of the food, but food insecurity is there. And then there are healthcare access issues and financial and non-financial. So the first step is we need not only to understand each of them separately. For within our South Asian community to understand what is the overall number of risk factors do they have, and which of them are related to the heart disease, and can they be used as a flag to identify those at risk, and then what do you do about them. So it's a definitely more challenging, but I think the direction that we are heading, especially with more big data applications, an ability to collect more data, run surveys, and with the wearables and the iPhones and Samsungs, where you can collect these information, I think in the next 10 years, we'll be able to not only accurately identify, but also relate the risk, but have specific interventions. But it's so true that there is an immense gap in this space, and we need to address that.
Thank you, Dr. Nasir. So the next one from Mrs. Lata Samu. What should be the heart rate when being maybe when we are exercising? And she also said like it's a very good presentation with a lot of good information.
Thank you. So, the heart rate, it all depends. It's usually trying to achieve 85% of your maximal heart rate, and it takes about an age group. So, I tell patients that getting your heart rate up to 150, 160, even 170 is not a problem as long as you have no symptoms. If you start having symptoms, of course, then it becomes an issue. Um, if you are starting exercise for the first time, there is a need to gradually increase yourself and getting to a point that you're pushing yourself beyond your comfort limit, something that's making you feel a little short of breath or getting outside your comfort limit. Some people, if you are deconditioned, your heart rate may go up much more quickly, whereas people who are more prone or are more into aerobic exercises, their heart rate may not go up quickly. So again, there is no right answer out here, I think, but a safe point is, irrespective of your age, you can definitely push around 150. If you're younger, around 160 or more, that's kind of the zone where the fat burning zone. But if you have symptoms, slow down, and that would be an indicator that you may have significant disease, like getting severely short of breath or unable to push yourself beyond, or you're getting chest tightness. Definitely see your doctor. But if you have no symptoms, in that range should not be an issue.
Thank you. So there is another question from Facebook. So this is from Mrs. Sushma Dikshit. How does the heart condition affect the kidney and vice versa? That's due to side effects of hypertension, medication, etc. And how can the patient with multiple risk factors like diabetes and hypertension manage the sodium potassium imbalance?
So the relationship is a little more reverse. For example, impaired kidney function, because it can cause increase in, I would say, blood pressure and some other conditions can affect. We know that patients who have reduced kidney function are more likely prone to develop plaque or heart failure. Now, how does the heart condition? So when we talk specifically for the heart conditions, unless and until you have a reduced pumping capacity that your heart starts failing, it doesn't tend to affect the kidneys, because if your heart pump is not doing too well and severely in the late conditions, your kidney may not be getting enough blood. But there are shared risk factors. So the two most important things that affect the kidneys and also the heart is hypertension and diabetes. So those both causes small vessel disease of the heart and the blood vessels. Now there are many medications that affect, of course, the blood pressure medications, because it is affecting the blood. There is a lot of interaction and mechanism that alters the kidney function. So it all depends. If you are diabetic and you're looking for blood pressure, so there is a certain class of blood pressure pills called ACE inhibitors and ARBs, which helps reduce by interacting with some of the kidney functions, help control the blood pressure. So yes, there are some medications that will affect the kidney function, but most of the time, actually, those are the pills that may lower the kidney functions are recommended. So the blood pressure management is a little complicated. Definitely talk to your physicians before starting any pills. Make sure your electrolytes or the kidney functions are closely monitored till you get to a stable level. But in general, early heart disease should not cause kidney damage, but kidney damage can impact your heart disease.
Thank you for that answer, Dr. Nasir. And there is another question like, is there any medication or pills that you can have on hand and take it when you experience heart attack symptoms that will save you until you get into the hospital?
Right. So usually it's basically and traditionally having aspirins on hand is going to be helpful. But in the end, if you're having any chest discomfort, call 911. Make sure you get to the hospital as soon as possible. Taking 4 baby aspirins or even more can help at least give you that protection of preventing the clot getting worse, but that's not going to be enough. In the old days, when we had patients who used to live with a lot of advanced heart disease, that when they walk, they used to get the chest pain. So there was this pill, the nitroglycerin, that you can put under your tongue that dissolves and helps open up the arteries. But we don't see that often. And honestly, not many people are carrying aspirins with them. But if there is one thing that you think that you are at a higher risk or have, my suggestion would be screen yourself so that you can overcome that concern. Uh, Rather than carrying more pills. But if you have those diseases, significant disease, then it may not be that futile. So I don't think that in 2020 there's going to be much significant value in carrying those pills. The best thing is call 911 as soon as possible.
Thank you for that one. And another question from Dr. Charles: are low levels of vitamin D3 a risk factor for cardiovascular disease?
The one space that NIH and our nation has spent the most federal funding is the vitamin D research. And it would have been a fantastic if vitamin D was actually a risk factor. So yes, we have seen that there is some association that people who have low vitamin D levels, again, because they may not be exercising well, or the diet's not effective, or they are overweight, or for other reasons. But I can tell you over the last 20 there are multiple studies after studies after studies that have clearly shown that vitamin D supplements will not impact your heart health, your brain health, your heart health, and many others. So I think so. It's on the decline. We don't really check vitamins D that often. And even if there are lower, maybe for bone health, it may be important. But for blood pressure, for diabetes, for heart health, there is no real association. And more importantly, no benefit of treating yourself if you have a low vitamin D.
Thank you for that one. Okay. So I think no more questions I see. And Dr. Nasir, and I end with my last question. So I think you mentioned there are also people who can experience heart attack without atherosclerosis, right? So what are the risk factors for those people?
So those are pretty, I would say, very rare if you don't have atherosclerosis. Especially in women, you can have a certain dissection. So the arteries, you can have a rupture in the small arteries, dissections that can happen, but usually pretty rare. These individuals may have some underlying elastic tissue disorders, but if you're looking at almost about 95% or more, or all the atherosclerosis or the heart attacks are secondary to atherosclerosis. Sometimes what happens is you may have atherosclerosis that's blocking the arteries, and there is a certain increase in demand of the heart. For example, you go into an irregular heart rhythm, or you become severely hypotensive, that you're unable to mismatch, so you can have some small heart attacks. But in the end, my one big take-home message is think about atherosclerosis, the fat plaque buildup in the arteries, as the main culprit. If we can focus on identifying the individuals early on and maximizing the preventive therapies, even in our 30s or 20s, to focus on lifestyle to prevent or it developing, screening individuals at age 40, and then focusing our efforts, especially with the right medicines who have early atherosclerosis, we can make a huge dent in reducing an acceptable, I would say, event in our society, that most of our folks in their 50s and 60s get heart attack. That's normal. I think so that's not normal, and we can truly limit that.
Thank you for that one. And I think no more questions. And it's really great pleasure for having you, Dr. Nasir. It's really a wonderful seminar. It's very much needed.
What I truly want to tell you is what a fantastic job you guys are doing in spreading out the words and getting the communities together to focus on these key issues. And Kudos to you, and I hope we can do more of these seminars, and hopefully post pandemic have big local organizations in these larger metropolitan take the message out, the gospel out to the people who need it. And again, I know that it's going to be Thanksgiving. I hope that everybody remains safe with their family and a heart healthy diet. And hopefully, I see that you have a virtual gala on December 12th. I'll make every effort to join to be among the friends. But thank you so much for bringing me in this group. Really appreciate it.
Thank you, Dr. Nasir.
Take care. Bye bye.
Take care.